Let's see about procedural errors, prevention and management. So procedural errors during endodontic therapy occurs not only with students and beginners but also the skilled and experienced clinician. In spite of taking all possible precaution, it can occur. So the procedural errors are classified into three types. First one is related to access opening of the pulp space, and the second one is related to canal shaping and cleaning, and the third one is related to obturation. So the first one is related to access opening of pulp space, and second one is canal shaping and cleaning, and the third one is related to obturation. Let's see the first one, that is related to access opening of the pulp space. So the main errors and challenges faced during access opening procedure, these are the points. The first one is treating the round tooth, and the next one is incomplete removal of caries and access opening through the full coverage restoration and inability to locate extra canals, that is a missed canal orifices, and iatrogenic perforations, that is cervical perforations or occur. These are the procedural errors occur during the access opening of the pulp space. The first one is treating the round tooth. So arriving at we have to take a diagnosis and designing a treatment plan before beginning any procedure can definitely bring down the number of procedural mishaps, and making the pre-endodontic notes and make a suitable marking on the radiograph and also on the tooth in question in the oral cavity before the application of the rubber dam. So this before the marking is help to avoid the treating the round tooth, and alternately as an option it is suggested that the initial access cavity into a enamel or dentino-enamel junction can be completed before the rubber dam placement. These are the clinical notes that help us to improve the or treating the correct tooth, not treating the round tooth. So these are the point we have to note it. So we have to take the X-ray and treatment planning before the procedure, and initial cavity preparation done before the rubber dam application. These are the point. And the next one is incomplete removal of caries. So secondary caries under the existing restoration is one of the reason for the need for endodontic therapy. So we have to use under magnification if any doubt exists about the presence of secondary caries. The entire filling must be removed and the access has to be redesigned accordingly. So secondary caries, we have to remove the entire filling and remove all the caries, and it is recommended that an existing old restoration, especially involving occlusal proximal area, should be removed and in a total and access cavity design accordingly. So this will prevent any chances of secondary caries being left behind when endodontic procedure is completed. So these are the steps. So distal caries lesions involving the pulp. These are the other reasons, and access is success. So we have to done access cavity in a perfect manner, and pre-operative diagnostic radiograph are taken. We have to note the root canal configuration, and there is a calcification or present or not, and there is any unusual morphology and angulations of the tooth. These are the point we have to noted. And the third one is access opening through the full coverage restoration. So when a patient presents himself or herself with an existing crown in the tooth that is planned for endodontic treatment, the best solution is to remove the crown. It is very important. We have to remove the crown and proceed the endodontic treatment and then go for a new crown. This is the classic treatment. If the soft caries lesion is suspected under the crown from radiograph, one should take a clinician decision to remove the crown. So burrs are available for cutting through the ceramic crown without chipping of the crown. So these are also available for cutting through the metal crown for easy access. So orientation of the burr and maintaining the parallelism according to the long axis of the tooth, especially in the maxillary lateral incisor and mandibular first premolar, become difficult. So the third one is access opening through the full coverage restoration. Here the clinical note is, if the patient having pain or we have to do endodontic treatment in crown wearing patient, first of all we have to remove the crown and then go for endodontic treatment. This is the classical treatment for these patients. So the fourth point is missed canal orifice is very important. The canal orifices, missed canal orifices reason for causes. So failure to externalize the internal anatomy while studying the preoperative radiograph, and lack of knowledge pertaining to root canal anatomy, configuration and its variation, and improper access and not observing the basic cavity design features, and incomplete de-roofing of the pulp chamber, and incomplete removal and shaping of the lateral wall of the pulp chamber, and the access openings in both maxillary and mandibular molar are always on the mesial half of the occlusal surface, rarely extending across the midline. So these are the points we have to remember while treating this patient. And in maxillary premolar, the opening is always buccolingual. So mandibular first molar with a middle mesial canal, and mandibular second premolar with 4 canal. These are the cases we missed the canal. And then go for the prevention and action. So good periapical radiographs preoperatively during the root canal cleaning and shaping, and observe the radiograph under magnification, and multiple radiograph in various angulation is also needed, and use DG16 Explorer. These are the points for missed canal orifices. And the fifth error is iatrogenic cervical perforation. So here they usually occur in the form of gouging. So leads to crown perforation caused by direct impingement non-parallel to the long axis of the tooth. The iatrogenic cervical perforation, doctors are the reason for this conditions. So we have to the non-parallel to the long axis of the tooth is proceed this condition. And management of non-focal cervical perforation, here the primary protocol is hemorrhage. First one is hemorrhage control with 1:50,000 epinephrine is given if the perforation is made. So and it is repaired with MTA, and keep periodontal treatment options open. And the prevention, so the crown root angulation of maxillary lateral incisor and mandibular first premolar we have to keep in mind. And care must be taken is not removing healthy dentin and undermining the crown tooth structure, and repeated X-ray are needed for prevent the errors. So these are the management of cervical perforation. So management of cervical perforation in the furcation area. If it is in the furcation area, flooding of the blood into the pulp chamber. Definitely there is a lot of blood in the pulp chamber, and we have to use electronic apex locator. And MTA, mineral trioxide, is a material of choice for these conditions. So management of cervical perforation of the furcation area, these are the MTA, mineral trioxide aggregate is the material of choice. For sealing perforation, the patient should be informed that procedural error has occurred. So guarded prognosis is communicated to the patient. And the prevention, we have to take the preoperative radiograph and evaluate the pulp chamber morphology and access birth penetration for death, and angulation should be confirmed before proceeding with designing the access cavity. And straight line access is a cardinal rule in all access preparation. So it is very important, straight line access is needed. And with the maxillary lateral incisor and mandibular first premolar, always follow stay lingual rule. So maxillary lateral incisor and mandibular first premolar stay lingual. So while preparing access cavity, so straight line access is necessary, and maxillary lateral incisor and mandibular first premolar stay lingual rule. If crown present, better we have to remove the crown. And when there is an existing restoration, it is safer to remove the old restoration to rule out any secondary caries is present. And if there is calcification in the chamber or pulp space, the endodontist must externalize the internal anatomy of the pulp space. Then moving on to the second one is procedural errors that occur in the canal shaping and cleaning. Canal blockage, first one is canal blockage and ledge formation. and the second one is deviation from normal canal anatomy, and the third one is separation of instruments, and the fourth one is obstruction by previous obturating material. So these are the errors that occur in cleaning and shaping procedure. So the first one is canal blockage and ledge formation. Here the canal blockage is occur due to the apical pushing of the dentinal debris. While we have to that dentinal debris, we have to remove that during shaping and cleaning. So what are the prevention? We have to use the smaller size instrument first, and then use the instrument in a sequential order, and always pre-curve the stainless steel hand instrument. So smaller size instrument first, and then sequential order, and pre-curve the stainless steel hand instrument, and use reproducible reference point and stable silicone stoppers on instruments if we have to use, and use copious amount of large amount of irrigants we have to use. Always we have to work in a wet canal and recapsulate repeatedly. If there is a loss of working length at this step, take a radiograph and dispose of used instrument. What is sledging? It is an artificially created deviation of the root canal wall that prevents the passage of an instrument to the apex of an otherwise patent canal. So it is an artificially created deviation of the root canal wall. So what are the causes of ledging? According to Zoffazudat and Abbott, the common causes of ledging are not extending the access cavity sufficiently to allow adequate access to the apical part of the root canal. So the not extending access cavity, and complete loss of control of the instrument, and incorrect assessment of the root canal curvature, and erroneous root canal length determination. So working length measurement is we have to proper measurement of working length, and using a non-curved stainless steel instrument that is too large for a curved canal, and failing to use the instrument in a sequential order. So rotating the file at the working length. So that is overuse of the reaming action, and inadequate irrigation and lubrication during the instrumentation, and overlaying on chelating agents, and attempting to retrieve broken instrument, and removing root filling material during endodontic treatment, and attempting to prepare calcified root canal. These are the causes for the ledging. If there is a broken instrument, we have to retrieve. That attempt is also producing the ledge formation. So the next one is prevention of the ledge formation. We have to take the preoperative radiograph for assess and anticipate the unusual root canal curvature, and patency of the canal should be maintained throughout the procedure, and recapsulation with a smaller instrument is needed, and work passively without forcing the instrument into the canal, and never force an instrument apically is very important, and work sequentially by increasing the size of the instrument without jumping the large numbers. These are the prevention methods. The second point is deviation from normal canal anatomy. So here is the zipping. So zipping is defined as the apical transportation of the curved canal caused due to improper shaping technique. So it is a apical transportation of the curved canal is called zipping. So the clinical notes here are always pre-curve the initial small sized hand instrument, and do not skip the sizes of instrument, and never rotate the instrument in the curved canal. So these are the clinical notes we have to remember in the case of zipping. So the file rotated in a curved canal at the apical area, the biomechanical defect that is caused elbow. So the less flexible instrument may overcut the outer surface of the curved canal and may produce an elliptical preparation in the apical third that is difficult to obturate. So this elliptic preparation in cone shaped, so with the apex or elbow toward the middle third of the canal is called zip toward the cementum surface. The second one is transportation. Instrument remains within the confines of the root canal, but the elliptical preparation will produce internal transportation of the foramen, and if the instrument is outside the confine of the root canal, it will produce external transportation of the foramen. So here the transportation, if the instrument is within the canal orifice, it produces internal transportation. If it is outer, that is produce external transportation of the foramen. One is elbow. So what is elbow? Elbow, it is the narrowest portion of the zipped canal. A zipped canal is apical to elbow and usually obturation end at the elbow. So elbow is the narrowest portion of the zipped canal. So creation of an elbow is associated with the zipping and describes the narrow region of the root canal at the point of maximum curvature. So management, so we have to prevention this condition, and thermoplasticized obturation technique most preferred method. So in elbow cases, or we use thermoplasticized obturation technique most preferred method in these cases. And the third one is instrument separation in the canal. It's occur in the cleaning and shaping procedure. So instruments separate or break only when they are used incorrectly or overused. If the instrument fracture in narrow canal or in the critical apical third of the canal, it becomes very difficult to either remove or by the bypass of the instrument. So the prognosis and management of the separated instrument inside a canal are depend upon lot of procedure. So the level of instrument separation in the canal, that is coronal, middle or apical third. So before that, we are going to see the pursues and measures recommendation to minimize the incidence of instrument separation. So create a glide path and pattern with a small hand file, and straight line access and good finger rest is needed, and crown down shaping technique depending on the instrument system, and use stiffer, larger and stronger file, and use a light touch on the instrument and never push hard, and touch retract action with large increment allowed by the particular canal anatomy and instrument design characteristics, and avoid jerking or hurrying of instrument. And the file used in narrow and curved canal have to be replaced immediately, and examine the used files regularly, preferably under magnification. And the canal should be flooded with sodium hypochlorite as the instrument is passed through the canal, and avoid keeping the file in one spot, particularly in curved canal. So what are the prognosis and management for this condition? Here the level of instrument separation in the canal, that is coronal, middle and apical third, it depends, and size of the instrument and degree of the infection beyond the level of the separation, and operator skill and patient motivation and decision of the future course of treatment. These are the points for prognosis. The treatment plan is instrument retrieval and bypassing the instrument and making it part of the obturation, and surgical intervention in the form of hemisection of the root or root resection in the root with apical third instrument separation. So if the beyond apex instrument gone, we have to raising the flap and remove the instrument. These are the treatment for the instrument retrieval. The fourth error is obstruction from previous obturating materials. So when the retreatment of a previously endodontically treated tooth becomes necessary, so the filling material must be removed or bypassed. So the gutta percha. In gutta percha, and sealer can be removed by the application of, we have to apply the mechanical force in the form of instrumentation and heat to sear and soften the gutta percha. And so we have to use, we may use the solvents and ultrasonics and combinations of the above. So gutta percha removed by heating an excavator blade or plastic instrument blade and searing the exposed gutta percha. And other methods are number 20 or 25 H file or GG, gates, glide and drill burr. We have to use, and we may use solvents if gutta percha is stuck in the middle root of the canal, and soften the gutta percha and permit sequential instrumentation. And we may also use chloroform. It is a solvent, but it is not recommended because of its toxicity. And the third procedural errors are with obturation. So one or underlaying of the GP or overfilling of the GP. If it is underlying of the GP, there is a insufficient GP, inability to seat the master cone to estimated full working length. So due to loss of working length, it results of packing dentinal mud and into the pulp space without recapsulation or insufficient irrigation. So underfilling of GP is due to the recapsulation or insufficient irrigation. These are the causes for the underfilling of the GP. If it is overfilled, so we have to take the X-ray to identify this condition. And the second one is overfilling of GP. So shaping of the canal beyond the working length and continuous tapered funnel preparation and is mandatory. So tapered funnel preparation is mandatory, and accurate estimation of the working length and reproducible reference point is needed, and verify working length and adhere to cardinal rules of shaping and cleaning. And apical stop is mandatory. Master cone is placed slightly short of the working length in wide canals. These are the points we have to remember in overfilling of the GP. Another one is other procedural errors, aspiration or ingestion of the endodontic instrument. It can be a clinical disaster, ending up in life-threatening situations or ending up in the need for major surgery to remove the instrument. இன்னும் யாரும் இல்லை.